just turned on the microphone, so we'll just make sure that we get some feedback in the chat, if that's okay, that we've got the sound right. We're just having a couple of technical issues. But welcome again to another weekly webinar on coronavirus, COVID-19. Thanks for the feedback there. So we'll continue, the sound is working. Perfect. So we'd like to, first of all, acknowledge the land that we're meeting on today. For us here at the AMA SA offices, we're on the land of the Kaurna people, and we'd like to acknowledge the land wherever you're meeting on, wherever that is nationally or across the state, and we pay our respects to elders past and present. So we're going to have a start with Dr. Louise Flood first from the CDCB, the director there. Is going to go through some of what's been happening in South Australia this week and a little bit of background in latest developments. And then we've also got Dr. Tom Dodd, the director, Clinical Services Director at SA Pathology, to give us a bit of an update about testing. And then in the room here, we've got Dr. Danny Byrne, GP Liaison, Dr. Chris Moy, who's the AMA SA President, and myself, Dr. Emily Kirkpatrick, representing SA Health GP Liaison and also the RACGP. So we'll start with Louise's talk, if that's all right, and please remember to post questions in the Q&A box.
Okay, thank you all for joining today. So I'm really just updating on the epidemiology firstly, and then just thought I'd just quickly talk about the testing criteria, because I'd mentioned it last week, but I think what I had was maybe a little confusing, so I've just put it in again. So far, this is the epidemiology from last night. Over 1.3 million confirmed cases worldwide, with close to 75,000 deaths, with most of those deaths occurring in a few countries: Italy, Spain, USA and France. The case fatality rate has increased slightly. It's now approximately 5.5%. And as mentioned before, the case fatality rate really depends on your testing and who you're testing. And if you're only testing, if you're testing sicker people versus everyone, it will affect your case fatality rate. And just looking at the number of cases across the world and just by cases reported, and again, this will be affected by the testing. And if the country is not testing, they will have fewer cases detected. So you can see there's a few hotspots there, so hotspots in the United States and in various countries in Europe. This is just showing the epidemic curve from the confirmed cases in 100 days after the first number of, the number of confirmed cases in the days after the first 100 cases detected, and just showing how quickly it has increased or not in various different countries. And you can see, looking at Singapore in the brown down the bottom, and I believe that's Japan, that they had quite a lower slope to their curve once they reached 100 cases, that they really haven't had that huge increase, whereas as compared with somewhere like the USA, where it's gone up quite a significant number of cases in a shorter period of time. And Australia is there in the red, so we're sort of in the middle, but then we have been slowing off more recently. So epidemic curve for the globally, again showing that initially the cases were occurring in the Western Pacific region, so in China, and now we've got large numbers of cases in Europe and the Americas, with really a quite steep increase in numbers over the past few weeks. This is the number of cases in Australia by jurisdiction as of yesterday, and you can see as of yesterday we had close to 6,000 cases with 45 deaths. Still a large proportion of the cases are overseas acquired, and a large proportion of the cases are occurring in New South Wales. There have been the 31 cases which are locally acquired but had interstate travel. So we've got 6 in that case. So we think they've acquired it in one of a different state. And then there's the 548 who have been locally acquired with no contact identified, and most of those cases have been in New South Wales. But you can see that it has slowed over time. The number of the increase has decreased. So as in the change in the last 24 hours is only a 2% increase in overall in Australia. And this is a good curve showing the epidemic curve in Australia, and that includes the various times that different things happened. So there was a bit of quite a reasonably steep increase initially, and then over the last sort of couple of weeks, there's been quite a decrease in the number of cases that have been reported. And that is likely to be related to all the bans that we've had regarding a large part of that is likely to be due to decreasing the international arrivals. So looking at the cases in South Australia, this is as of yesterday, that we had 415 cases with 286 of those overseas acquired. And 112 locally acquired but are known to be a close contact of a confirmed case or in a cluster. And then 4 with where we haven't identified the source of that infection, and 6 that have travelled interstate and no specific contact identified, but they have travelled to another state. And we still have 7 under investigation. And yesterday we only had 4 more cases reported yesterday. And just looking at our epidemic curve, it sort of mirrors the national one, that there was quite a bit of a steep increase there, and then it's levelled off significantly. And you can just see there are still a few cases under investigation. And just to be clear about that, we're always investigating when we get new cases, seeing if they have links to earlier cases. So something that we may say something that's not really still under investigation, but we still always are looking for more links. So I think, and this data always changes in this sort of thing. And we might find some information that we had before was incorrect, or we might get further information that can put one of these cases into a different category. And looking at the age and sex, so predominantly it's occurring in adults, and with fairly even distributions across males and females, and these are the South Australian cases. Yeah. And we now are using reporting on both confirmed and probable cases. There was a change in the case definition around a week ago, where probable cases is now a category. We've actually only got 1 probable case at the moment, but it's basically someone who's a household contact of a confirmed case and has a clinically compatible illness, but hasn't been tested. So it have to be a household contact, so it has to be really quite clear that they are likely to be a case, and so then they're a probable case. And we haven't done that very much at the moment, but I mean, usually we are recommending testing, but as the outbreak progresses, we'll find that we'll use that category more and more as we, with more cases, we might find that we don't test those ones that are highly likely to be cases, and so fit that probable case definition. And just this is just a cut and paste from the public health alert that came out last Wednesday, but I just thought it was maybe a little clearer to have a quick discussion on that. So basically, people need to have both an epidemiological criteria and clinical criteria to be meet the criteria for testing. This is for COVID testing, these are recommendations, but you can also, if you do have someone that you want to do testing, as COVID is on the respiratory panel anyway, that testing would be done for anyone that you are suspecting another respiratory illness for, and you want to do a respiratory panel. But it's basically the close contact of a known case, international travel, interstate travel, cruise ships, as well as the 2 areas that we're of an increased risk, and that is people in the Barossa, particularly those towns and the regions just around and near those towns, and people who've also been to the Adelaide airport, including the terminal and car park. Now that is in relation to the cases that we've had regarding the baggage handlers And we are also really just being quite wide there with that category, just to make sure that we're not missing any cases in the airport area. And then we've also got the high risk settings. So these are basically where if you have 2 or more cases in that area and it's a high risk setting, such as aged care and really residential care, residential facilities such as correctional facilities, detention centres, as well as also the setting of Aboriginal, rural and remote communities. That is where we're really wanting to pick up those any cases occurring there quickly, so that we can make sure that they don't spread in that facility or in that Aboriginal area, Aboriginal, rural and remote communities. And also then there's the moderate risk, and that's just the healthcare workers, aged care and residential care workers, which is really that same concern that we really want to pick those cases up early so that they don't spread. And then the clinical criteria is as we've had before. And isolation, I've talked about this before, so just put that up again, it hasn't changed. And isolation is the same, stay at home, only people who live in the home should be coming, no visitors, and also practicing that social distancing within the home. And the only reason to leave the home really should be to seek medical care, urgent care, and a mask should be worn if you need to leave the house. It's a notifiable condition and you can notify it online, and the importance of infection control as a way of stopping this. That's all I have.
I just saw a question pop up. The residential aged care and those where there's detention centres and so forth, yeah, you need 2 people to be unwell before you call it a criteria for swabbing.
Well, that's the criteria for as per the public health alert.
Yep.
But these are guidelines. There's always that clinician discretion that for some reason you are able to swab other people if you think it's warranted.
Right.
And I think that highlights that if you are concerned that someone has influenza type symptoms, for instance, and you worry about them in a care setting, that would be more than reasonable to swab that patient. Because we are seeing influenza cases still. I think there was 11 cases of influenza in the last week reported to CDCB.
And there'd be a COVID-19 on the panel.
Yeah, so I think it'd be highly clinically sound to absolutely swab your first patient.
Thinking that it might be the flu.
And it may well be, but it could also be another thing, including COVID.
Yep.
Well, you had a question saying it, and I'm just going to try and get the questions going so we try and get through them all tonight. At what point are we doing too good a job? So what would be your answer to that, Louise?
Look, I mean, we do know that it is it's a nasty disease. There's been huge numbers of deaths overseas, and we do need to keep on testing. When you get your cases that you think might be COVID, make sure you test. We need to make sure people continue to do the social distancing and all the people that are recommended to be quarantined or isolated should be. We will get more cases, and it really is in a way a national decision about whether we change any of those recommendations regarding the restrictions that are in force. But I mean, expect more cases.
Yeah, and I mean, it is really tough, isn't it? I mean, one question we've had coming through is around high-risk settings. Does that also include fly-in, fly-out mining workers who are living in boarding-type mining site housing? Would you include that in your definition, Louise, when we talk about boarding schools? Would we include mining sites where there's large groups of people living together? Yeah, so it's not been identified as a specific site, but it really is anywhere that's this sort of, live-in type setting. So yes, I think if you had a case there or a couple of cases in that sort of setting, yes, you would want to test them. Perfect, thank you. So we're going to now move to Dr. Tom Dodd, and he's going to give us an update on SA pathology. I'm just going to open up his presentation here. I mean, Tom, we've already had a few questions coming through around the the point of care tests, and a number of GPs have had these marketed to them. So what are your thoughts on that in terms of, is that something we should be worried about? I know the legislation's come in banning that, but certainly GPs have had a lot of this sort of data and information sort of put in front of them.
Yes, so with regard to the point of care serology testing, apart from the fact it's actually illegal to use them in South Australia at the moment, more broadly, I think it's very important to understand what that test does and doesn't provide for you. So in the first 7 or 8 days of the infection, obviously you'll have a high viral load, be contagious, and if you do a point of care serological test, it'll almost certainly be negative. So that'll be a false negative in terms of actual diagnosis of the illness. It's also important to bear in mind, even if you were to get a positive result, some of these tests are clearly showing cross-reactivity with presumably other coronavirus infections from the past, which account, of course, for a lot of colds anyway. And the third point would be that a significant proportion of the population, older patients, people with immunosuppression, won't mount a sufficient serological response and would have similarly a false negative result. So right at the moment, it's generally felt by most infectious diseases physicians and pathologists with expertise in the area that it's not really a valuable test at this stage in the pandemic in Australia. Down the track it will be. It'll be really important to understand people who've had asymptomatic or minimally symptomatic infections, and I'm sure we will be introducing that on a regular basis in the not too distant future. In fact, today we were putting through paperwork to purchase the right instruments to do reliable serological testing. So I will be providing that in the not too distant future, but it's just really a question around timing of when we should be using that. I thought people would be interested to see where we are travelling with testing here in Adelaide. As in South Australia, we've done about 35,000 tests now. What's interesting, the graph at the bottom shows the number of tests per day, and it has trended down a little over the last week. We sort of had a high watermark a couple of weeks ago with 1,600 cases, and now over the last period we've dipped under 1,000. So there are no doubt a number of reasons for that, not the least of which is that we've mopped up probably most of the international, interstate and cruise ship returnees, I guess there hasn't been such a demand out of the Barossa, but we certainly have the capacity to do more testing, and I know there's a discussion going on with the CDCP around what the criteria may move to over the coming period. So if you have clinical concern about a particular case and you think, yeah, maybe I should be swabbing this person, don't feel disinclined to do it because you're worried about reagents. We're travelling pretty well in that sort of way. We've done most of our modelling around doing between 1,000 and 1,500 tests a day, and so in that regard, I think we're fine in terms of reagent.
So what you're saying is, if in doubt,
I would test. Yep. I would definitely swab patients at the moment. If you've got someone with compatible symptoms, useful to know if they've got influenza anyway, I would definitely be swabbing them.
Thank you.
South Australia compared with Australia right now in terms of screening per million of population, you've seen this before, this is the graph up to date. So I think in part we've done very well because we've got a very good handle on where the infections are, and then Louise's team have been able to do a sensational job tracking and isolating these patients, and I'm sure that's accounted significantly for why South Australia is in such a good place now compared with New South Wales and obviously just about everywhere else in the world. Couple of other things relevant to just general clinical practice. We are opening 2 specific collection centres for blood collects from patients who are immunocompromised, patients with various, they'll be treated for cancer or got immunosuppression for various reasons, drugs or other conditions. One will be in Unley, which is a new collection centre, brand new one, and the other one is up in Elizabeth. what we'd ask you to do is actually make booked appointments, or the patients to make booked appointments to come in at specific times. So we don't want people coming in just off the street for their blood tests. It'll be for those people who are vulnerable because of immunocompromise. So we think that'll be helpful.
Right. So you maintain social isolation.
Yeah, that's right.
Social distancing.
Social distancing
inside these places.
Trying to avoid people that are could potentially have other sorts of infections.
And Tom, Professor Brendan Murphy, is that his name? The big dude in Canberra. He said the pathology tests are roughly down 30 to 40%. Just your normal everyday blood tests.
Yeah, absolutely. You're probably noticing that in your clinical practice. Our figures are exactly like that. There's been a significant decrease in all those sort of routine screening tests, I guess, lipids and so forth.
So people still need their HbA1c's checked and their cholesterols and their electrolytes for their on their diuretics. So still, normal clinical practice should continue.
Yeah, I think that's incredibly important. We sort of forget that there's 10,000 other diseases that we're treating at the moment.
Yeah.
It feels like that. So that will be in place as of next Tuesday, straight after Easter. I mentioned about reagents. Swabs, once again, we're managing the swab supply. We have sufficient swabs. We've acquired some additional specific bacterial swabs, which will help preserve the other swabs that can be used for virus swabbing. So that'll offset that a little bit. Negative results, so we're very close. Either Tuesday or Wednesday next week, we will be sending out by SMS negative COVID results to your patients, which I think will be a huge step forward.
And Emily and I can attest we were the guinea pigs.
We tried it out,
and we registered, and seconds later we got our negative result. So I think that will be hugely reassuring to the public, because at the moment there's a bit of a, if you don't get called, you're okay, and there's just too much anxiety out there.
Yeah,
people want to know that they're negative.
Yeah, absolutely. So I think that's going to be a big step forward. It's very problematic. We've got 1,000 or 1,200 tests a day. 99% of them are negative, and you're getting millions of phone calls. We're getting millions of phone calls. I've had pathology registrars ringing through negatives all week for certain patients at certain sites. So we're very happy when that's done. There'll be an expanded domiciliary service. So that will be for routine blood tests for certain patients, particularly immunocompromised patients. We're going to do that for paediatric patients in particular, but also an expanded capacity to do domiciliary collections for COVID testing out for nursing homes and so forth.
And we had a question about aged care facilities, and particularly for nursing homes, if there's going to be an option for that to happen in the future, Tom. Yeah,
that's right. So we're just bringing on board a larger number of nurses, so we've got a sort of a capability to do that. So we'll be communicating with you all about how that will work. I mean, it'll be essentially similar to the current system, and the requirement to go through the CDCB to get permission essentially for a domiciliary COVID testing won't be necessary once we've got all the staff on board, which would be good. You would be aware that SA Pathology paused enteric fecal testing about a week or 10 days ago to preserve reagent. ClinPath Laboratories have very kindly agreed to take on those community tests for us. So we're still receiving the specimens into SA Pathology. They come in from regional areas and so forth, as well as in Metro Adelaide, and then we're forwarding them on for ClinPath for analysis. So, and we will continue to do that until we're confident that we've got a very secure supply of reagent, because it's the same reagent really for all sorts of testing for all sorts of organisms, whether enteric organisms or COVID or influenza, etc.
Fantastic. Thanks, Tom, for that. We've had lots of questions come through in the chat box, and I apologise. We're just doing a bit of a computer swap, so I wasn't able to see your questions coming through in the Q&A. But just from things that have popped up, we've had a few ones that have come in around the Barossa, and whether you feel that that's testing a group of asymptomatic patients up there. We're getting a bit of a sample of patients up in the Barossa potentially with asymptomatic potential COVID patients. That's come through from a couple of people questioning that.
So, I mean, the recommendation for the general recommendation is still people have to have a clinical picture to recommend testing. So we're not recommending testing of asymptomatic people. So if someone is in the Barossa, they meet the EPI criteria, but they don't meet they need to meet that clinical criteria as well. Now, there might be some exclusions come in the future regarding that we might want to test asymptomatic people, but in sort of very high, you know, when there's an outbreak in an aged care facility or something like that. That hasn't occurred in South Australia as yet, but there might be some exceptions. But generally, we're not recommending testing of asymptomatic people.
Yeah, I think the issue there is the drive-through clinic didn't require a GP referral, so the word got around that you could just drive in and you get swabbed, and so some local residents took advantage of that.
So what I'd say about that was it was not clear what the demand would be. There was a COVID clinic established at the hospital, and at the time that it was thought there'd be a need for a large number of people to be swabbed up in the Barossa, we set up a drive-through clinic in Tanunda. From the experience with the other two drive-through clinics, we thought it might be more straightforward if people could have their request forms completed as they drove through, and Dr. Sharon Morton, the local health network EDMS, is the medical signatory at the bottom of that form. As it turns out, there really hasn't been a huge number of people coming through the drive-through anyway, and I think the numbers over the last week in general, there was only a handful of people through today, for instance.
Yeah.
But it has been encouraging because we haven't detected a lot of cases there or anything, which is really what we wanted to find out was there a lot of cases occurring in this region.
Yeah.
So encouraging. In a funny way, it's actually probably not a bad thing that we've had something of a sampling of a relatively asymptomatic people.
Yeah.
That's comforting in a way.
Can I ask, Louise, is it possible that this criteria about the Barossa just gets dropped, or will it stay forever? I mean, I don't know how it works.
We'll have a look, but yes, I mean, that may drop at some point if we find that we aren't getting the cases there. Yes, well, I mean, we're always looking at that, and it may be that it comes off the criteria at some point. And same with the airport. When that settles down, it might come off the criteria.
And maybe for anyone to comment on, but anecdotally, we've had reports that have reached ministerial level where patients who reside in the Barossa have been refused healthcare in the city, ranging from don't come and have your flu shot, we don't want you. You're from the Barossa, don't come and have your chemotherapy, we don't want you. Dentist not going to treat acute dental pain because you live in the Barossa. These are asymptomatic patients. So just like to take this opportunity to remind all the GPs out there that just because you live in the Barossa or you might work at the Adelaide Airport, if you're asymptomatic, you are allowed to see these patients and treat them, and don't discriminate against them.
So I mean, that we put out about the Barossa and the airport, that is a testing recommendation. So it's about if that person has been in the Barossa or in the airport and they're unwell with a COVID-like illness, to encourage you to test them. Everybody is meant to be minimising their travel, whether you're in the Barossa or anywhere in South Australia or Australia. You really should only be travelling for essential purposes, and to go to your work and go home, that type of thing. Urgent medical care, to go and get your food. You're not meant to be travelling around anyway. But I do echo what Danny said, that there's no people who are from the Barossa still need urgent care, still need to get their health care. They're not, that was really our testing criteria.
So it's almost like an overreaction to this announcement about the Barossa. But we don't want to discriminate against people just because they happen to live in the Barossa or happen to work at Adelaide Airport. They're not lepers. So, and these complaints do reach ministerial level, and Emily and I in SA Health are having to deal with these. So, can reflect poorly on the health profession if we start discriminating against people. You're allowed to give them a flu shot. It's okay.
We've had a few questions come in about retesting. So if someone is clearly unwell and we're concerned that they have COVID and they meet criteria for testing, they're tested, it comes back negative, they're still really quite unwell, is there a value in retesting those patients a period of time later?
We know that at least a small percentage of first tests will be negative for various reasons. So if you're clinically concerned, I would most definitely retest your patient.
Right. And is there a time frame you would suggest that you would wait, 24, 48 hours before doing that? Obviously, you've got the result back. You've probably already had that time.
You've probably got that lag
Yes,
time.
yeah.
I think, I would just retest.
Because they'd be getting worse. So
Yeah, that's exactly right.
It's not just that the cold is persisting, it's that they would actually be getting the fever and the cough and the fatigue and the headaches, all these terrible symptoms they complain of. So.
And then we had someone who has mentioned here that they had a test that was performed, it came initially as negative and then changed to a positive result. Are you able to explain that at all, Tom? Is there a particular that you have borderline results at all with COVID testing that would change that into a positive result?
So the other way around, there had been one or two tests that we thought were borderline positive, but were probably actually negative early on as we were getting more familiar with the test. I am aware of one case, and maybe this is the one that's been quoted, which was tested on one analyzer, was a borderline result that was repeated, was negative, and then just at this time we're setting up additional platforms, in fact 2 other platforms, and I gather that test was repeated on the second platform and returned a positive. So if you're doing 35,000 tests, all laboratory tests, like all tests, are not 100% perfect. So I'm not surprised we've had 1 or 2 like that.
Yeah, that's
which is interesting.
Yeah.
But that just goes back to the clinical. You have to take into account your clinical picture with any laboratory test that you get. If you get a test you don't think it's right, you still have to put the clinical picture in context with that lab result.
It's always sound. It doesn't matter what it is. If you think there's a concern with your test, first repeat your test.
And in terms of repeating tests as well for the criteria around coming out of that isolation, and we know with community positive patients not doing a test of cure at the end once they're symptom free for that 72 hours after 10 days, is there any value in patients having a test done? We have had people come back to us saying that they would like to have a test done. Can they have a test done at that period of time? Is there any value to that? We did have a question that was put through by email around this, in terms of one housemate was a healthcare worker, the other one wasn't, had gone away out of isolation, had met the 72 hours, so had the healthcare worker. They had been tested and they came back positive despite being symptom-free. So I just wasn't sure, is there any scope for that in terms of testing at the end of that period of isolation for people who are particularly anxious or perhaps are going to go into a high-risk non-healthcare environment?
So we're not recommending testing in the groups that don't need to be tested as per the release from isolation guidelines. Firstly, it's a waste of a test. So that's one criteria. But also, then we get if that test is positive, firstly, it's a PCR test. So we don't actually know whether that person's infectious. Because whether they, if you did a viral culture, whether you would actually grow the virus or not. So the PCR is always that marker of whether there's still the nuclear material there. So it may not be that person's infectious. It's a marker, and so it does get you down this little rabbit hole of you do a test. If it's positive, then you'll need to do another test so that they meet the other criteria of you end up doing more than the test that you need if it does be positive, and we don't even know if it means that person is actually infectious either.
But you flip it around for the healthcare workers because you want to make sure that absolutely.
Yeah, the healthcare worker guideline, and people in aged care, healthcare, and people who work in aged care or healthcare or are aged care residents, we've got that higher criteria because it's just so much more important that then they're not infectious, and we just have that higher bar.
I had a test done on myself on Saturday morning, and I said to the nurse, really, do it, I want a proper test. And she said, I think I got a brain biopsy. So, and tears were running down my eyes. So
That's always a good sign.
Yeah, it was a proper test. So if I had to have one of those every 24 hours until I got 2 negatives, I think I'd retire from medicine.
And just one final question for you, Tom. It was around, so for rural areas that are undertaking testing, for instance, Mount Gambier, where there's quite limited transportation now to those areas in terms of flights going down there, with Rex only doing a flight a week. What are your thoughts, and have you had any concerns around rural testing at all in terms of timing of swabs and logistics associated with testing?
We've been doing a lot of work to secure transport routes for all the regional sites. Toll planes are used quite extensively as well, including for Mount Gambier, so that's important. What I can tell you is that as soon as we're able, we will be putting rapid testing kits into each of the regional laboratories. The timing of that will be really dependent upon when the US manufacturer Cepheid makes the cartridges available. We've seen the first of them just now, but the larger rollout to be able to do this in a consistent way probably will be more likely the end of April, early May. But that will be extremely helpful.
These are PCR.
They're PCR tests. They're to detect the viral RNA. Same test, and we've had them in the metro sites for some time now to support rapid diagnosis of flu.
Right.
So we'll hand over to you, Chris. Is that all right? Sorry, I thought we'd just get through some of those questions so we don't have about 400 like we did a couple of weeks ago.
Put the mic a long way away from me because of my very loud voice, which is not my normal one for my children, which is why they complain that I scold them all the time. Is that loud enough? Everybody good? Can we have?
I'll monitor the chat if there's any problems, Chris. We can move it.
They're going to go the other way, I'm sure. Look, just the usual stuff, the flowchart. Can I talk about the health pathways again? Can I just say particularly, we all have the people, all the people on the chat are all the conscientious people. It's the people in the rest of the clinic who can't be bothered and need to be spoon-fed. Put them onto health pathways, because health pathways is all the links. Just send them there, because we all have those people in our clinics who just keep on asking us because they can't be bothered reading anything. So send them here. And the best thing is now there's a standard username, which is COVID-19, and SA password is the password, and they can get in straight to the COVID site. I just think, like people on the line probably can answer all the questions, and the ones answering the questions for the clinics. Send those people to the ones who are asking questions, send them to Health Pathways, because you can spend a lot of time repeating the same thing again and again. MBS, I'll just quickly go through MBS. We talked a lot about this last week, was about the new items and also the practice incentive payments and the frequently asked questions. And just to repeat, the consent issue is basically need to ask for verbal consent and for financial consent, and you need to document it. And also there's the removal of the 12-month rule. Now, and also the issue is you do not need them. Please don't get them to sign forms anymore for a while, and get them away from those ATM buttons as well. Just seems completely pointless to do that at the moment. But just, we do it under the unable to sign provision. Right, COVID-19, highly infectious pandemic, at risk of exposure to COVID-19, etc. Now, just about the big question this week has all been about the private billing. Now, I'll clarify, there's been a lot of confusion early on. So let me explain the situation. This is the bit I'll spend the most time on. So as of Monday, all available telehealth items for both GPs and non-GP specialists were able to be billed privately for patients other than those who have a Commonwealth concession card, children under 16 years, and this is the tricky one where everybody's been up in arms about, is patients who are more vulnerable to COVID-19. Now, part of this was because there was a bit of confusion about what was going on and what the intention was, but now the next bit will make you cross, but just bear with me. The intent of the government is to make further amendments to regulations next week that will allow only non-GP specialists, so GPs will still be held to that, to determine who they bulk bill without restriction. So the non-GP specialists, as of next week when legislation changes, will be able to a discretionary privately bill without reference to those restrictions, Commonwealth concession card holders, children are 16 years or more vulnerable. Now, right at this moment, I know that everybody's been up in arms about that and have been asking a lot of questions about it, but let me explain a couple of things. The first thing is the AMA is currently clarifying what vulnerable to COVID-19 is. That is firstly under the national definition for a possible confirmed COVID case that needs isolation or testing. So that is quite a strict criteria. It's not the state criteria, it's the national criteria. The second thing is that we are trying to get absolute clarification about the determination of a vulnerable, and vulnerable is otherwise, and we're going to get better guidance on this, but it's otherwise determined by the doctor on clinical grounds and guidance being to do it. So a lot of people have said, oh, there's chronic illness like they've got reflux or they've got thyroid disease. No, they're not. They're not more vulnerable to COVID from reflux, okay? So it's not a chronic illness per se. It's just, are they more vulnerable? Clearly somebody who's immunosuppressed is going to be, but people who are not. But these minor conditions do not constitute an increased vulnerability. So look, again, you just got to use common sense and use clinical guidance with respect to this. We will be getting some guidance out apparently, that's the thing. So there'll be a clarification. Danny, did you want
I would have thought, the criteria for a doctor to be able to do telehealth from home, they're over 70, they've got a certain number of conditions, they're on immunosuppression drugs. I mean, that you can flip that around and say, well, that's the vulnerable population who's vulnerable to COVID. So there's a rough guideline there. Yeah, so it's going to be it's going to get tightened up. So the issue is that it's not going to be everybody with a chronic illness. So it's going to be quite a small group. Now, the thing is that then we'll still have a problem though, because I know, I can hear it now, everybody's going on that there's this gap. You've got the people who are actually concession card holders and under 16 where we get the double bulk billing incentive, the double bulk billing incentive. And then you've got this, the ones who you can privately bill who are clearly outside of that. But then you've got this other group who would be in the vulnerable group who may actually not have a concession card, which you would only be able to charge the bulk billing rate without any bulk billing incentive. So the AMA is currently negotiating with the government about this sort of thing, and we hope to be able to bring that bulk billing incentive in for that group, so which will help bridge the gap. I know it's not the same, but it's better than nothing. And I think the reason why, okay, people will look at this and say, why are the specialists getting this and GPs are not? The main reason is that general practice has had an infusion of $500 million for the next 6 months, which the specialists have not. That's the reason. $500 million. So that's the fastest infusion of $500 million we've had for a long time. So I think we have to get a perspective on this. The AMA is trying to bridge the gap. It ain't perfect, but you've got to get it out there. A lot of other people are hurting. We're actually bridging the gap much better than others. And that's because people are understanding our important role out there to keep the health system going. So that's the bottom line. So we will be able to only bill, privately bill within those, outside of those criteria. That does include CDM items, that's my understanding. You can actually privately build them, but I don't think many of us do. And then later, we're going to clarify the definitions and we're going to lobby for that gap people, the people who are private, who don't have a concession card holder but fit the vulnerable group, to be able to get the double bulk billing incentive, hopefully over the next little while, working hard on that. So that's the clarification for that. Provider number, I already mentioned that. Now, e-prescribing, that's the other biggie, which will be mulching your brain right now. Just bear with us. So, at the moment, as of last time, there were these interim solution which you were able to create a digital image of a signed prescription. Please sign your prescriptions.
Physical signing.
You actually have to sign the prescriptions. Getting a lot of complaints from the pharmacies that they're getting scripts that are not signed, actually not legal. Their signed prescription in a photo or PDF with a barcode scan. You were able to send it by email, text, or fax to the patient or the pharmacist, but then within 15 days you had to send the paper one. The reasons for this was, number one, we couldn't have people going to 5 pharmacies, and the second thing is for PBS requirements under the national legislation. Now, let me explain that as of last night, we removed the national requirement, at the national level, there's now been a removal of the requirement for the original script to be sent to the pharmacy for them to have to claim PBS. So that's actually changed of last night. So we now remove that. We have a couple of solutions, so bear with me. At the moment, as of today, if you don't want to send the original, script by snail mail to the pharmacy, your option is to fax or e-fax an image of the signed script to the pharmacy with the dispensing pharmacy named on the script. And then there's the no need for the original to be sent to the pharmacy, and that includes S4 and S8 drugs. That's now. You can do that now. So that if you write the name of the dispensing pharmacy and fax and e-fax, you cannot text it at the moment because there's a problem with the definition of what electronic transmission is under legislation here. So at the moment, can I give a shout out to Naomi Burgess and her team and SA Health, who've been working really hard on this, along with the feds, who've been working really well. And we're trying to get this little bit through to change the definition of what an electronic transmission is. So that will then include a fax, email, or text image of the signed script to the pharmacy, and the doctor will be able to keep a copy of the original signed, has to keep the keep a copy of the original for 2 years, and there's no need for the original to be sent to the pharmacy. This will not allow, this will be the national one, that'll actually be the national overall option. So you fax, email, text an image of the signed script to the pharmacy, not to the patient, to the pharmacy, and the doctor then can keep the original signed script for 2 years, and you don't need to send it. It doesn't apply to S8 or S4 drugs, including benzos, some S4 drugs, including benzos. Now, what that means then is what we'll end up with is a 2-level thing for about a month or two. We'll have this one, which is for most of them, which most people will be able to do, fax, email, or text an image, hopefully very soon in the next few days, to the script, and you just keep the signed script for 2 years. But the problem is we'll still have the benzos and the S8 and S4 drugs, and if you don't want to send the original, you'll have to fax or e-fax it with the dispensing pharmacy named on the script.
There's a question about, is it e-fax same as scanning a script and sending a PDF? It's not, is it? An e-fax is a special piece of software, commercially available software, that makes your computer into a fax machine. So it actually pops out at the chemist end as a fax. So be careful that e-fax is a specific terminology, and it's not scanning and emailing off a PDF.
Can I just say, though, off the bat, it's so stupid.
Oh, yeah.
Since it's gone to NBN, it's all digital anyway. This is nutty stuff. But anyway, it's legislated, so sorry. So just in summary, I hope that understand. This is the world we want to be in the next few days. You can do the bottom bit now if you don't want to do scripts. Okay, you can do the bottom bit, which is fax or e-fax the image of signed script to the pharmacy with the dispensing pharmacy name of the script, and that's all S4 and S8s. And hopefully, as soon as we get the go-ahead, we'll be able to fax, email, text an image, PDF, whatever it is, to the pharmacy, straight to the pharmacy. The doctor has to keep the original, and you don't have to send the original. Okay, hope that makes sense. Sorry, it's a bit messy, but we want to get to here. Now, fast track, I've been in contact with the Australian Digital Health Agency just over the last little bit. And basically, the ultimate is we'll go to e-prescribing and that whole thing about it straight out from your thing with the digital signature and the token straight to the patient first. And later we'll be doing it through the prescription exchange service.
They're still thinking about May?
Yeah, there's a fast track. No, it should happen. It's just, as you know, it's trying to get all these vendors to get together. Personal protection equipment, just quick things. We'll be quick. If you've got any queries about, we'd be interested if you have any issues with obtaining it, feedback on costs and interest in supply. We're looking at a potential supplier who looks legit. So maybe it looks more expensive than some going over ahead, but we've also heard that people have had their PPE sort of stopped at the border because it's a bit dicey.
Yeah.
So
be careful of those made in China.
Yeah, but just keep an eye. We've got one who looks reputable and it's Australian standards. So if there is, we may be looking at it. But it does look a bit more expensive than some of the numbers we've seen. So yeah, if you want to feedback to that, feel free. Just a bit of a plug for Masks for Australia. This is a little thing with a lot of people out of work at the moment and wanting to contribute. There is an initiative called Masks for Australia. So you put your patients onto this. This is not for medical masks. This is for the creation of cloth masks that there is some evidence overseas, and I think it's starting to head that way, that maybe individuals in the community could be wearing cloth masks, particularly if they're sick or if there's a chance they've got COVID. And it's a sort of a social and community-driven process to make the mask and then distribute it to people out in the community who could wear it. Okay, it'll be the new trendy thing. So yeah, I've seen some trendy ones already. Cancellation of non-urgent surgery. I'll just reassure you again, procedures undertaken in a community setting utilising local anaesthetic by primary health and allied health practitioners within the scope of practice can continue at this stage. So you need to put an implant on in, and you just got to keep rolling with that stuff. That's urgent.
Yeah. I'll just let everyone know I was involved in drafting that little 2 lines there, and the police lawyer I was with said normally this is a 12 to 18 month process of consultations, and I was given 15 minutes. So I did the best I could, and we've got some plastic surgeons and dermatologists who aren't too happy with me, but my role is GP liaison in SA Health is to represent general practice, so that's what I did.
Good on you, Danny. And we worked very hard to get that through, so that was great you worked very hard.
Nagging My Health Record, you're going to see actually a little bit more in the community about My Health Record soon, because there's a real push on My Health Record. At this moment in time where we're trying to work by health, it's a way of actually having that communication out there. So really try and start thinking about putting, particularly if you're doing the care plans at the moment, getting a medical summary, a clean medical summary up there, please. We've had some more input from these guard. There's actually a local distributor now that has come to us down at Lonsdale and whatever. They're about $95, I think, these sort of plastic acrylic guard things. So if you've got any queries, just get back to us. So we've got a local supply. We've had some issues with the previous one. We were sort of trying to get going here. So give us a yell if you need that. Just about this thing called the 7-step pathway, you're going to see I'm working with the palliative care service. They're trying to streamline their service to something like a single phone line for advice, because they may be needed. But one of the big pushes that'll be on will be potentially initiatives for doctors to complete this resuscitation or that 7-step pathway. It's not, now I've got to play this very sensitively. A lot of people may think that we're trying to push, the wishes of, making judgments about the value of life and that sort of stuff. No, we're not. What we'd like to do is for people, and we know many of those, and many of the patients that I've worked with in aged care, who would rather stay in their home and frankly have palliative care than go to a hospital, that if we can get those filled out but not for transfer to hospital, that will make a big difference, because then you actually save potentially an ambulance service having to turn up and having to expose themselves, make difficult decisions, and that will really help the health services and potentially also stop inappropriate admissions to an ICU bed with a ventilator when really the individual may never have wanted it. So again, it's not about, and I don't want to get into this, Netherlands have been accused about this actually, but I really want to just be very sensitively say this. There are a lot of my aged care residents who I can tell you now do not want to go to hospital, and we need to support them. If we're going to do that, you fill this thing out and you tick that box, and if they agree to it, and then you write up some morphine and midazolam, and to make sure that if the time comes that at least they've got the backup of medications to relieve their distress, if that is their wish, that they want, if that's the direction they would like. So I just want to bring that up.
And Chris, can you make some of these guidelines and links available to others? Perhaps would you be able to send them through to us, and we might be able to distribute them out as well? We've had a few requests for that. Thank you.
Cool. So that's it for me. Oh, by the way, the most important question is, with Easter, is the Easter Bunny getting an exemption?
Yeah.
On the 14 days, Louise.
No, it's very hard to get an exemption.
Come on. The kids are suffering out there. They're in their homes. They're in isolation.
It's a zoonotic infection.
So I was going to give you just a little bit of an RACGP update. So we are in the process of organising an RACGP webinar on telehealth, which will hopefully happen in the next week or two. And as Chris has said, everyone's been working so hard in the space of telemedicine, and we're so thankful to all the bodies who have been fighting so hard for this at a federal level. What I will just talk a little bit about now is around the GP assessment service. So we've had quite a few questions, and we put out some information about that today in our daily update around the processes that was changing in this space. So we were having usual GPs managing patients in the community who were positive for COVID. This has now changed from now on. So patients who are diagnosed from now on will be managed by the Metropolitan Referral Unit, which is MRU, for those who are wondering what MRU was. And so how this will work is that this ensures that the process is very streamlined so that there's no patients who are, getting 4 calls a day or some patients getting a call every second day. This allows patients to have access to a nurse calling them up to 4 times a day, talking through temperature checks, talking through their symptoms, and ensuring we have a very clear pathway for escalation in case a patient becomes unwell in their home. And so the GP assessment service is run by, is undertaken by GPs here in South Australia who call up the patient to undertake a risk assessment. And as part of the risk assessment, it's determining whether the patient is safe in their own home and what the risk is to others as well at that time. And they talk through not just the clinical aspects, but the non-clinical aspects. So that includes food supply, are there issues with pets in the household? Are there issues with other family members? Are there vulnerable people that are involved that they look after as well? So after that assessment takes place, which can be anywhere up to an hour, that discussion with that GP, a referral is then sent to the LHN, so the local health network, which will be, in many cases, will be the Royal Adelaide. If you're in rural areas, it'll be through your LHN area there. And so what happens with that is they receive the referral, and then the next day the nurse or whoever is contracted through that LHN will call up that patient and check on their symptoms. And they have a very strict criteria. They have already been undertaking this process for the patients who have been tested in some of the COVID clinics already. So what we found was people were getting all different ranges of care. So this is to streamline that process. And then if they have any concerns, they will feed that back to the GP assessment service, but also have the ability to escalate through the EDs and have specific contact points within the EDs of the COVID admitting hospitals. So this process is to make things easier for the patients and to make things more streamlined at SA Health to make sure that patients are not falling through the cracks. In terms of, well, how does this work with usual GP care and chronic disease? What's really important is that you can still, as their GP, contact the patient and check on them. There is absolutely nothing stopping you from doing that. But what we do want to emphasise is this is so that patients can have a very risk stratified process and to ensure that they all have the same questions asked. So thank you so much to the GPs who have been looking after these patients in the community. This will still continue for those patients that you are looking after. This is just for new patients. And currently we're sitting really nice and low, which is fantastic, with only 5 new cases today. Danny and I will be sending out tomorrow some more information and fact sheets on this process. It is all very new, it's very unfamiliar, and we are very happy to take questions and emails about the process, but we will be sending out information as well. And so a few questions have come through around this in terms of, what's the Metropolitan, what are the options then for rural patients with the MRU? So each LHN has their own process. They're all following the same flowchart that their COVID liaison within the LHN will organise that patient to have hospital in the home and nursing outreach as well to them. And that may be through the MRU service where they're called up from a Metropolitan service but have access to the local supports. In terms of, is this going to be available on the SA Health website? Yes, this will be up on the SA Health website. It has just been all finalised this afternoon, the documentation for this, and we'll send that all out for you tomorrow with the links directly to the website, as these will be live documents as we continually update this information. In terms of other questions that have come through, just wanted to address, and we'll just talk about this as well. It was around aged care facilities and patients being transferred with COVID symptoms. So Chris, you've spoken quite a bit about this already in terms of, the concerns around aged care facilities being particularly vulnerable places. What are your thoughts and concerns around those facilities in terms of managing those patients? If for instance, the GP is going in, they're really concerned that this patient could have COVID, what would you suggest to them in those situations? Because we've certainly told them that they should be organising swabbing. We've got SA pathology coming on board with that. But, what are our concerns in terms of placing those vulnerable patients then into the ED system?
I mean, I think, again, you've got to actually work out whether they should be transferred or not, and the sort of stuff that I talked about, advanced care planning and advanced care directives and the 7-step pathway, that sort of thing. But I would certainly still be seeking advice about that. I'd be willing the local COVID team to manage it in terms of advice from the management of the infectious side of things, and then past that, normally there's going to be the medical side of things as well, and potentially the palliative care side of things as well that you may need to go to. I mean, if you think it out, there's really the issue about the first stage is actually working out, how you're managing an individual which is potentially infectious. And I think you have to manage that in the context of that individual and how it relates to the rest of the organisation, I think, and you need to get some advice for that. And then beyond that, after that becomes a medical issue, because if they're deteriorating, you actually need some advice about how to manage that. I think it's separation of it. Like when I've actually had a couple of these potential cases, it's kind of working out the infectivity first, but you've got to treat the medical side of things as well. Don't forget that they are almost separate issues, really, to some degree. But certainly the COVID team will often tell you, look, if it looks like it's actually there's an infectious risk, we need to actually manage it medically, then we're going to head down that line, and they may need to be potentially, for some people, admitted through the side door at, say, Royal Adelaide Hospital, for example, but you've got to do a lot of liaising about that.
Really tough. I mean, some of the other things to also think about as well, we talk about all these vulnerable populations that we worry about with COVID. I just want to make mention of another vulnerable group in our general practice community, and that is the registrars. That was my segue into that. And so we've certainly received some feedback from registrars who have been quite worried about themselves as employees in practices around PPE supply. And we've had a few people reach out around, are they going to be able to access PPE from the PHN? Is there a provision for them if their clinic is not putting those orders into you? Can they approach the PHN to be able to get access for PPE for registrars to then go and swab patients and feel safe in that environment? What would your thoughts be on that, Crystal?
Yes, as long as the EOI is coming from a practice, then we will support the practice with the PPE required. As we're all aware, there is a national shortage of PPE, so we're doing our best. Everyone's doing their best to source it, and we've certainly managed to get some really good, supply in recently around surgical masks and some more P2 allocation. Some gloves and gowns, very limited, but we do still have that. We managed to receive a very limited supply of hand sanitizer also today. So we are more than happy to support practices with their PPE requirements where we can, I guess is what I'm trying to say, given the limitations. So it may be that we supply with some this week. There may be a bit of a backlog in getting some more gloves, let's say, and then it may just mean that there's a little bit of delay in what we can push out and when. But definitely registrars working inside general practice, I would encourage them to speak to the practice manager, so they're concerned, we need PPE. PHN has the EOI on their website. Complete the EOI, send it in to us, and we'll get the PPE out to practices as soon as we can.
And the EOI, that's expression of interest, there's a form.
Yes.
Yeah. And country PHN, there's you fill it in a form on the actual website.
It's Louise, just wanted to say that we're not expecting people to test if you don't have appropriate PPE. So if you don't have the PPE because you haven't been able to get it, refer your patients through to one of the testing clinics.
And ensure you're following the clinical guidelines for testing and what PPE you need when testing. So for severe patients, and jump in anyone if I'm incorrect, but that's when we're using our full kit of PPE, our P2s, our gowns, our gloves, etc., where when we're just testing, maybe for some mild or moderate, you could use a surgical mask if you felt comfortable doing that, still obviously with your gloves and gowns, etc. But we need to make sure we're following the clinical criteria for testing. This then helps us with PPE shortage because we're making sure that the PPE is being utilised for its intended purpose.
Some good news, just breaking news this afternoon, Chris, and from the PHN about the first respiratory clinic. You able to comment on that?
So my understanding is the respiratory clinic, which will actually be opening at the Agaba Medical Centre, which is one
It's the Agaba Medical Centre!
Yeah, and I'm more than only there. I have no conflict of interest, okay, so just leave me alone. But I think the idea of this group is it's different, okay? So the idea of this is essentially it's a self-referred thing from patients. They're not the ones that fit in the criteria. That's the point. They don't. So we have this group of other people who are not fitting in the criteria. They may fit into the worried well, but they also are. I've certainly had these funny patients who are kind of grumbled on with something that, you just do wonder whether the community spread, and they're self-isolated. They're a place where they can be tested. The criteria is, as I understand it, is essentially respiratory symptoms that are not acute so bad that they need a significant that whole P2 mask, and they're sputtering and they look as though they've got a pneumonia. They're not the ones that this is set up for. So there'll be one, as I understand, setting up at the Aqaba Medical Centre, and there's going to be one north and south as well. Is that right at this stage? And it's got to be the first. So I think the one at Aqaba Medical Centre opening tomorrow, and then it'll be open next day. It'll be office hours at 8:30 to 4:30, I think, and it'll be starting tomorrow, and then over the holidays we'll be back early on Tuesday, Monday to Friday.
Not open over Easter, which is fair enough.
Yeah,
that's fine.
But really, these are the lesser normal respiratory type illnesses, and they'll get a COVID test. The result will go back to the usual GP. Yeah. That's important to know that. So,
but it's good to know that this is starting at the Aqaba, because a lot of clinics they're very happy to see patients who that they've screened out for respiratory illnesses. So these patients who say, well, no, you can't come to my practice because you have got a respiratory illness. You're an option now, or the Aqaba is an option now. Yeah.
Can I just say that with the Aqaba, I will give a shout out to Raf and Vic there, who've set up a good thing. I mean, they've done clever things like set up 2 teams as well. Have a think about that. Set your practice up into 2 teams because of staff, nurses, doctors, so that they can alternate with telehealth and on site, because you realise that if one team goes in and they get infected and they have to self-isolate, then at least the other team can go in and actually still staff the place and run the place. So, I mean, that's the sort of clever stuff that they've done. I'm sure other places have done it as well, but it's just common sense.
I might just mention to everyone online, no names, but there is a GP who's in 2 weeks isolation because he or she swabbed a patient who turned up positive and they weren't wearing the full PPE. They're doing 2 weeks in isolation
and taking out the staff. That's the problem.
Well, I think it was I'll leave it at that.
Yeah. So just some strategies like that are clever.
And it's interesting you say that, Chris, about working, 1 week on, 1 week off, and A and
one
B,
day off,
one day
off,
or however you plan to structure that. I guess one of the concerns that I've had as well raised is through registrars who are employees of the practice not having access to printers and computers at home to undertake consulting. So, I mean, that's certainly something that you need to look at in terms of your contract, and the NTCR would be the advice that we've given out, because the provisions are there to supply equipment to undertake your role is in there. So some thoughts around that you need to consider that with your employer.
I got to say, the office works. Printers are the new toilet paper. I just
on the flip side, as a practice owner, your use of your computer and printer and your home office at home is all fully tax deductible. So there's swings and roundabouts.
So fantastic. Thank you so much. We've got a little bit over time, but we were trying to keep it a bit shorter. We've got through most of the questions, only 13 left. So I'm just going to go through now and answer these, and we'll just talk through these. I'm sure many of you probably want to get going, and it's because of the change and it's very dark and it's cold outside. So we'll leave you to it. But thank you so much for joining in tonight, and we're so grateful.
And don't worry, we'll be working on Louise about the Easter Bunny. It's all right.
Yeah.
We'll
We've
talk to her
already put a
nicely.
message to Nicola.
I think we're going to have to go to Nicola's story. We're going to have to go to the top.
But I just want to say how grateful we are for you coming in, Louise, and for Tom coming in, because this has been now week 5 that we've done 5 of these now, these webinars, and we're so grateful that you come in and shared your expertise and be able to answer these questions. And so grateful to the PHN as well, with Crystal here with us, that you've been able to supply this as well for us.
And I think all of us would say a big hip hip hooray for Emily, who's been a fantastic chairperson for these webinars. I'll just say that we've never had less than 300 to 600 people dialing in. As a medical educator, if we get 30 or 40 people dialing in for a webinar, we go, wow, that's fantastic. So, and the other thing, Carolyn McAnally, the state manager for the RACGP, has just let us know that it is possible for you all to go online to the RACGP, and I imagine Akram might be similar, and self-nominate these webinars for 2 points of CPD activity. So if you've come to all 5, that's 10 points. Well done.
Fantastic. Well, that's pretty good, isn't it? Good, because you can log your activity that you do for this training to meet CPD.
Self-nominate.
There you go. Wonderful. So thank you so much for joining us tonight. This webinar will be available online, and we'll send it out tomorrow in our update. Thank you.
Good night. Stay safe.
Keep up the good work, everyone.